Okay, good afternoon, everyone, and welcome again to this week's multimodality imaging conference. I'm Dipan Shah, head of cardiac imaging here at Houston Methodist, and this week we're going to continue with our discussion on imaging for cardiomyopathies. So this is a follow-up to the lecture that we had a few weeks ago, where we talked about the role of echocardiography and CMR. And today we'll continue on talking about restrictive and inflammatory cardiomyopathies, and we'll speak on the role of CMR, and then Dr. Mouaz Al-Mallah, who heads up our cardiac PET, will also speak on the role of nuclear imaging in evaluation of cardiomyopathies. So let's get right in. Last time we talked about genetic and dilated cardiomyopathies, and today we're going to focus on the inflammatory and the infiltrative. And again, just to refresh your memory, one of the really kind of the key hallmark strength, I think, of cardiac MR is this ability to directly image tissue alteration. And that really rests upon the delayed enhancement or late gadolinium enhancement technique, where again, we can identify areas of myocardial damage as areas of high signal or hyperenhancement. But because of the high resolution and the ability to directly image this, you can also look at the pattern. So not just the presence and extent, but actually the pattern to see, for example, on the left-hand side, we have more of a mid-myocardial septal pattern. The patient in the middle here has a epicardial pattern of myocardial damage in the infralateral wall. And then this person on the right-hand side has a non-coronary perfusion territory pattern, where it's a global subendocardial pattern. All of these are indicative of non-ischemic myocardial damage. And we know that it's important to look at cardiomyopathies beyond just ischemic or non-ischemic. And the reason for that is the underlying etiology has prognostic implications as well, as is shown in this publication from Mike Felker almost 25 years ago. So let's start off with a clinical case. This is a 44-year-old woman, Caucasian, with really no past medical history. She presents with to the emergency department with 2 episodes of syncope within the past week, notes progressive fatigue and dyspnea for about 6 months. She denies any chest pain, palpitations, or P&D. And her vitals, blood pressure is 103/50. Heart rate is 43 and regular, and physical exam is noted to be unremarkable. Here's her 12-lead electrocardiogram, and you'll notice here that there's evidence of complete heart block on the EKG. The echocardiogram that was done reveals normal LV function, and maybe you might think there's a little bit of increased wall thickness in the basal septum, but otherwise really nothing impressive on the 2D echocardiogram. On the cardiac MRI, when we look at the cine MRI, you notice again increased wall thickness in the basal septum. But also interestingly, if you look at the lateral wall at the mid to apical region, seen on both the short axis and the long axis, there's increased wall thickness there. And then notice the RV. There's also increased wall thickness in the basal free wall of the right ventricle. You can see that both in the fourth chamber and the short axis view. So again, clearly some morphologic abnormalities that we can see just based on cine MRI imaging. But again, I think the hallmark strength is when we do the delayed enhancement or LGE, you'll notice, in fact, there's hyperenhancement in that septum, hyperenhancement in the lateral wall, as you can see here, both in the short and long axis view. And also look at the RV, that area where we see increased wall thickness, there's hyperenhancement or increased contrast uptake in that location as well. So if we pair this again with the ability to do T2-weighted imaging, either with T2 spin echo or T2 mapping, you can see that there's high signal in those 3 locations as well on our T2-weighted imaging, suggesting really increased water content and telling you that this myocardial damage that we're seeing based on LGE is not chronic, but is rather acute. And then a quick survey through the chest, as we do in most of our cardiac cases, will also show that there's evidence of hilar adenopathy and paratracheal lymphadenopathy as well. So if you put all of these things together, this constellation of findings is really highly suggestive of cardiac sarcoidosis. This person actually went on then to get a biopsy, which also confirmed, in fact, the evidence of cardiac sarcoidosis. And what do we know as far as the MRI literature with the role of cardiac MR in cardiac sarcoidosis? So this is one of the kind of the early studies from 2009, which looked at a series of patients that had known extracardiac sarcoidosis. And the objective was twofold. One was to identify myocardial damage based on delayed enhancement MRI, to look at both the prevalence as well as the pattern. What was noted here in this series was that compared to Japanese Ministry of Health criteria, which only identified an abnormality in about 12 or 13% of patients, there was evidence of hyperenhancement suggesting myocardial damage in nearly 1 in 4 patients within this particular cohort or series. But interestingly also, there were a variety of different patterns of enhancement from subendocardial, transmural, mid-myocardial, oftentimes affecting the right ventricle as well, and sometimes multifocal patchy distribution. And then this was a more recent study from a few years ago, which identified these exact same abnormalities, but actually looking at histopathology. So in this case here, they were looking at histopathology of autopsied hearts that were sectioned, that had known diagnosis of sarcoidosis. And you find very similar patterns on the histopathology itself, suggesting it's not just imaging findings, but that there's a histologic corroboration that you see with these variety of different patterns and findings that you notice. And then I think importantly, the other question comes down to if you have a patient with known sarcoidosis and you see abnormalities on your LGE, what abnormalities are suggestive of a high likelihood of cardiac involvement and, importantly, worse outcomes? And so in this series here that was published in JAMA Cardiology a couple of years ago, they looked at, again, all patients that had a biopsy-confirmed extracardiac sarcoidosis diagnosis. And if there was no LGE at all, the outcome in these individuals was quite good. No arrhythmias or heart failure events during the follow-up duration. For those that had abnormal LV function but no LGE, there were no arrhythmic events that were noticed. And then if you look at those patients that had some evidence of LGE, and again, this is a cohort of confirmed extracardiac sarcoidosis. There's those that had, kind of just a small area of abnormality that was, again, rarely seen on the pathology literature, and then those that had abnormalities that were either subepicardial, multifocal, septal involvement, and especially RV free wall involvement. And those are the individuals that were more likely to have arrhythmic events. And so again, I think where this informs us is that if you have patients that have known, confirmed, biopsy-confirmed extracardiac sarcoidosis, it's these abnormalities right here that really raise a concern that there's a cardiac involvement and therefore a high likelihood of events. And this is just, again, the Kaplan-Meier curves showing these findings. And then this now is a meta-analysis that looked at a series of 13 different studies, and again looking at patients with, in this case, known or suspected cardiac sarcoidosis, showing in fact that the presence of LGE is associated with a worse all-cause mortality, with an increased risk of ventricular arrhythmias, and an increased risk of a composite of death or ventricular arrhythmias. Let me skip past this here in the interest of time. And so I think, the way that you'll see patients in the imaging lab is really two pathways. One is in those patients that have known extracardiac sarcoidosis, where they have some symptoms that are prompting the concern for cardiac involvement. So those symptoms can be significant palpitations, syncope or presyncope, or individuals who have abnormal EKGs or abnormal echocardiographic findings. Those are individuals that may benefit from going on to imaging with cardiac MR to really identify the presence of cardiac involvement. And then the other is a group of patients that don't have any known prior cardiac sarcoidosis history, but who present with heart failure of unexplained etiology, VT of unexplained etiology, or high-grade AV block, especially in a young individual under the age of 60, as is the example case that I showed earlier, where in those cases, our cardiac MR is actually helping to, one, identify cardiac involvement, and then really to suggest the potential diagnosis of cardiac sarcoidosis. Dr. Al-Mallah will touch on kind of the complementary role between cardiac MR and PET. Let me move on to some other conditions besides sarcoidosis. So here's an example of a study looking at patients with SLE, systemic lupus erythematosus. And again, noticing several findings that were abnormal in these individuals. One, obviously, is the presence of LGE in these individuals. And then in addition to that, the presence of pericardial enhancement or pericardial inflammation that was noted in these individuals as well. And in fact, when they compared a control group to those with SLE, the pericardial abnormalities and then the myocardial enhancement were the findings that were separating the two groups that were uniquely distinct to the SLE group. Moving on now to another condition here. So if I show you just the cine images, what do we notice? Well, one, it looks like there is a small pericardial fusion that you can see here as the area of high signal. There's increased wall thickness. It's about 1.6 centimeters. The RV, if you look at the right ventricular free wall, looks also like there's an increase in wall thickness there of about 0.7 to 0.8 centimeters. If you look at the atria on this four-chamber view, there's biatrial enlargement with a reduction in LV ejection fraction. Again, not severe LV dysfunction, but rather just mild LV dysfunction with an EF of 47. And also mild RV dysfunction with an RV EF of 38%. And you notice that there's a significant increase in LV mass. So this increase in wall thickness is resulting in almost a 300-gram left ventricular mass. And then when you couple that, again, with the delayed enhancement findings, where this now is a post-contrast imaging, where what do you notice? You see that there is really diffuse enhancement of the left ventricle and the right ventricle. Notice also the atria show enhancement as well. The papillary muscle, you can also see enhancement in the papillary muscles as well. This is really kind of the classic finding that you see in amyloid heart disease. So again, it's not just the morphologic abnormalities that you can see by cine or by echocardiography, but really the tissue characterization abnormalities that I think really help stratify in patients with amyloidosis. And so in this series here, this was a multi-center series where they looked at a group of patients that had known extracardiac amyloidosis. And if there was any hyperenhancement present, the prognosis in these patients was much worse compared to those patients with extracardiac amyloidosis, but no evidence of hyperenhancement. This is a meta-analysis which also shows almost a 5-fold higher likelihood of having adverse outcomes for those patients with known systemic amyloidosis who also had evidence of LGE on CMR. And then one of the questions obviously comes up is, so what is the mechanism of LGE here in this setting, which again is different than in the ischemic or in the kind of traditional non-ischemic setting. And what you have here really seems to be that as there's proteins deposition in the extracellular space, it leads to an expansion of the extracellular compartment. And what we know is that our gadolinium molecules distribute to wherever there's extracellular space. And as a result, there's more volume of distribution for gadolinium in hearts that have amyloid infiltration, resulting in the hyperenhancement that you can see. And in fact, in addition to looking at it visually, you could also then, using newer techniques based on T1 or extracellular volume mapping, actually try to quantify the extent of the abnormality that you're seeing. And there's now a couple of papers, and this is just a few that I pulled recently, but there's been a few recent publications which have highlighted the potential for using MRI to try to look for serial changes in patients that are getting treated with for amyloidosis. So on the left-hand side is from a European study where they looked at patients that all had AL amyloidosis, quantified using extracellular volume mapping the burden of abnormality in the myocardium, and then patients that then went on to get treatment with chemotherapy for their AL amyloidosis, They reclassified the extent of extracellular volume expansion. And this is, again, proof of concept more than anything else, but suggesting that serial changes with treatment may be predictive of long-term outcome, as is shown in the group with AL amyloidosis at a 6-month time point on the left-hand side, and then a more recent publication which looked at patients with ATTR as well as AL, which again noticed that those patients who demonstrated a increase in extracellular volume at 12 months on serial imaging had a worse prognosis than those patients that showed stabilization or decrease in extracellular volume. So again, I think there's more work that needs to be done in this area, but the question is, could there be a role in using this to monitor effectiveness of therapy? Now let's look at another case. This is a 27-year-old woman who's admitted to the hospital with pneumonia and retrosternal chest pain. She has a small elevation in her cardiac enzymes. If we look at the cine images, what do we notice? And do we have any volunteers from the audience that want to tell us what they see here? Nobody? Okay, so this is not so much the pericardium as it is a pericardial effusion. Okay, this bright that you see here, because again, the pericardium would be unusual for it to be this extremely thick, right? And also when you see this bright, that's fluid. So there's a pericardial effusion. What else? Very good. Okay, so very good. If you look at the wall thickness here and just go around the circumference, right? The anterior wall is much, much thicker than the inferior and lateral wall, right? You can see that on the basal as well as kind of on the mid slices. And you can see here it's a little bit cut off, but on the two-chamber view, right? You can see the basal and mid slices. Wall thickness is much thicker than the other areas. Anything else?
So RV-free basal wall.
Okay.
Basal wall. It's also like thinner than the rest of the RV.
RV-free basal wall. Now remember, so let me ask you a question. What is normal?
Chamber.
Yeah, what is normal RV wall thickness?
Should be less than 1.
1 millimeter?
No, 1 centimeter.
Oh yeah, no, it's actually on MRI. It's actually about 4 to 5 millimeters. That's the normal wall thickness. So this right here, I don't know that I would call this a thinned RV wall. I would just say it's normal, probably. Okay. So looking at this, can anybody give me a diagnosis? Or not really, right? You say more information, right? You can always ask for more. So the one always right answer in MRI is if you can say, show me the contrast MRI, right? Because again, that's going to show you the tissue composition. So because the cine imaging it just shows you the morphology and function, but let me show you now the contrast. Okay. Now what do you guys think? So remember those areas that we saw increased wall thickness in the anterior wall? Well, the composition here is a little bit different, right? It's because again, on this delayed enhancement, you're looking for areas that are dark, black, which is normal, and areas that hyperenhance, right? Which is myocardial injury or myocardial damage. What you notice here is kind of like a multi-layer, right? There's the normal myocardium, which is dark here. There's an area of hyperenhancement here, right at the subendocardium, and then this really big black thing. What is that? That's probably a thrombotic material. And then you see a little bit of enhancement on the outside as well. So when you see this multi-layer pattern, does that make you think of something? Because some of this is also pattern recognition, right? And that's why I say it's important. You got to see lots and lots of cases because then you start to get good at pattern recognition. So this pattern, does it raise concern of anything? What? Yes. So you guys have you guys have looked at case reports, right? In fact, yes, when you see this pattern, this really makes you think about Loeffler's, right? So we said, oh, what is the eosinophil count in this person? White count is 20K with the eosinophil count of 67%. And in fact, yeah, this person does have hypereosinophilic syndrome. And interestingly, after treatment, so this person got 3 months of anticoagulation and steroids, and then we brought them back for follow-up imaging. And again, the top is the initial scan. The bottom here is the post-scan 3 months later. That increase in wall thickness looks like it's gone now, right? And if we look at the contrast imaging, now you don't see that multi-layer appearance any longer. All you see is just a nice black myocardium. So resolution of that abnormality. Now here's another condition I want to touch on, which is iron overload. So we know that iron overload affects the liver first, but it can then also occasionally go on to affect the myocardium as well. So obviously, with the liver, you could always do a liver biopsy. You could do liver imaging to try to look for iron composition within the liver. Is there a technique that you can use with MRI to look for iron content within the heart itself? And that's a technique called T2 star imaging, all right? And so this is a technique that's been around for over 25 years, and I'll just show you some example cases. The patient on the left here, notice the heart and the liver are both normal. In other words, they don't show the classic dark appearance that you would expect to see. And the patient in the middle here, who has sickle cell anemia, has received multiple blood transfusions. You can see the myocardium appears dark and the liver appears dark. And then the patient on the right-hand side, the myocardium does not appear dark, but the liver appears very dark. And again, beyond just qualitative assessment, using this T2 star-based technique, you can actually try to quantify the T2 star abnormality, which now there's been a number of validation studies showing that correlates directly with biopsy evidence of of iron overload within either the liver tissue or the myocardial tissue. And in this series right here, a T2 star value of the heart of more than 10 was associated with heart failure events during follow-up, whereas values that were greater than 10 had a very low likelihood of having subsequent heart failure events out to 3 years of follow-up. And so that's become the threshold that we use to say T2 star values of less than 10 are suggestive of severe iron overload. And then really normal T2 star values should be over 20. And so between 10 to 20 is kind of a borderline zone. And in fact, T2 star values now have become really the mainstay of how patients are evaluated for iron overload throughout the world, really. And this is actually just kind of an interesting graphic from the UK, which looked at the incidence of cardiac death amongst thalassemia patients in the UK population. And they noticed, and again, notice this T2 star technique became mainstay in the UK around early 2000s. And with the advent of this technique and the ability to directly quantify the iron content within the myocardium, they saw a significant reduction in cardiac deaths amongst their thalassemia patients. So again, showing that imaging may be useful from a diagnostic standpoint and from a prognostic standpoint, but it may actually help with therapeutic management as well to improve patient outcomes. So again, to kind of wrap up, what I think hopefully we showed over the previous lecture as well as today's lecture is that this ability with delayed enhancement MRI to directly look at the myocardium and identify myocardial tissue damage can be very useful. We know in the ischemic setting where we're looking at myocardial infarction, this technique can be useful to identify a subendocardial or a transmural infarction and the extent of the infarction, and that seems to be associated with likelihood of recovery of function after revascularization. And then in the non-ischemic purview, this technique can help to, again, identify myocardial damage in non-ischemic etiologies, but actually, based on the pattern of the enhancement, can try to help you to further narrow down a potential differential diagnosis as well. This, again, going back to the appropriate use criteria, you can see the role for cardiac MRI after initial evaluation has been done with echocardiography in really a variety of different conditions. And then I think really to wrap up, I think where MRI I think is useful is beyond looking at morphology and function is this ability to directly look at the tissue composition with our delayed enhancement techniques as well as our newer T1 mapping techniques, which I think can really aid not just in diagnosis, in prognosis, but also potentially in therapeutic management of patients. So thank you for your attention, and I'm going to turn it over now to Dr. Al-Mallah, who will talk to us about the role of nuclear cardiology in cardiomyopathies.
So, thanks Dipan for a great overview. And now we're going to continue from where Dr. Shah stopped. So, many of these cases you will see the complementary role of the different modalities and how we often use them in the diagnosis and management of these patients. So this is a patient that I saw many years ago during my fellowship, and patient came in with VT and syncope. 35-year-old, healthy otherwise, no prior disease. He was working on the field and just passed out, and the first rhythm that EMS saw was VT. When the patient was resuscitated and we ruled out coronary disease by angiography, we got an MRI, and you can see here the extensive late gadolinium enhancement that we see in this patient. It involves the RV, it involves the epicardial disease. So in this case, we know that this patient is having active inflammation, is having a lot of arrhythmia, and there's a lot of late gadolinium enhancement. And the question always that comes out is this acute inflammation or this is prior inflammation. When you have this extent, it's probably significant. There is some element of active inflammation, but sometimes you don't know if the arrhythmia is coming from reentrant arrhythmia from the scar, or you want to know if there is active inflammation, because the management of these patients is going to be different between immunosuppressants versus ablations and antiarrhythmic. So the test that has been widely used in these patients is actually cardiac PET. And what we do here is primarily we want to image the inflammatory cells. So we're not trying to image the myocardium. So the myocardium, the normal cells should take the perfusion agent, and we will image them by perfusion agents. But what we want is that these normal cells not to take FTG. And many of you are eating right now, so your insulin level went up. So when your insulin level goes up, your myocytes are just going to have your glucose. So if you get FTG, your heart is going to light up. So how do we do it? Opposite to what you are doing. So we use prolonged fasting, and this is how it was used for a long time. So patient would fast for 18 hours or so, and then they go ahead and image them. They found that this works, but doesn't always work as much in every patient. So we thought, what does the heart like? Free fatty acid. Why not give them free fatty acid for a long time? So patients, before they come to us, we instruct them no carbohydrates. We want them to be zero carbohydrates as much as possible. So our techs will call them, will tell them, don't eat these. We have a long list of things that they cannot eat for a long time. We usually try 24 hours, but now we're moving closer to 48 hours because we see sometimes some failure rates. So we give them the free fatty acid that the heart likes. Then we give them the fasting, and then when they come to us, we do perfusion imaging, and we also use heparin. And heparin is not every site used because heparin promotes lipolysis. So if you give them heparin, so there will be increase in their free fatty acid in the blood, and then we give them the FTG. So if everything works fine, the heart should not take any, the myocytes should not take any of that FTG, and now you're imaging specifically the macrophages and inflammatory cells. So a normal cell, a normal study will look like this, where you see the myocardium, but you see all the FTG in the blood pool because there is no inflammatory cells. But if there is, and this is how it looks on every scan, so we look at it in short axis, we can look at it in long axis also, and you can see the heart, and you see the different walls without any FTG uptake. In a positive study, you see a perfusion defect that usually matches the area of late gadolinium enhancement that we get on MRI, but then we can see also that there is reciprocal in that same area FTG uptake. So we know that that area of late gadolinium enhancement is just full of macrophages or inflammatory cells. And this is a study that's positive with these. There have been a lot of histological studies that confirm these, and also some biopsy studies and even some explant studies among patients who got transplanted after having FTG studies. So when we image them, we're imaging the heart, we focus on the LV, but we can also look at the left atrium, as in this patient, where you see the left atrium has significant amount of FTG uptake. Just gonna get my mouse up. Okay, so you can see that there is FTG uptake in the left atrium, and this patient was having 20 ICD shocks in one day. All of them were inappropriate shocks from atrial tachycardia that this patient was having. We can also look outside that and can see in the lungs. This is a patient who is having active pulmonary sarcoid, or in the mediastinum, where all these lymph nodes light up. So we're looking at cardiac and extracardiac, and the most common sites where cardiac sarcoid can affect are actually the lungs, liver, spleen, and obviously the heart. So technically, and abdominal lymph nodes and mediastinal lymph nodes. So with our field of view, we're able to see about 80 to 90% of where sarcoid is affecting. Now, it's very important to assess how accurate is the preparation. And this is one study where we can see that there is no perfusion defect, but when we did the FTG, there was like significant FTG uptake. So we asked the patient to go back and be prepared better, and now you can see this patient has no FTG uptake and so on in the blood pool. So initially it was like more based on the expertise of the readers, but we and others wanted to kind of formalize that. So after several studies, that including this study in our lab, where we found that if we can use beta-hydroxybutyrate, which is the test we use in DKAs, because with prolonged fasting, we're inducing ketosis. And in these patients, actually, if we use beta-hydroxybutyrate, at least in our lab, with a 0.4 cutoff, you have very high rate of suppression. In this study, we had like almost 100%. I'm aware of only 2 studies after we published this study that were called non-diagnostic or not well suppressed, with a beta-hydroxy between 0.4 and 0.5. So this data has been replicated in UPenn, and actually they found a cutoff of 0.45. So the numbers range between 0.45 and between 0.4 to 0.5. And now the good news is that there is a point of care assay, which is, you can use it qualitatively, like what the police use, and like when they stop someone to see if they are driving under influence. That's measuring beta-hydroxybutyrate, and some labs are just using that and kind of come up with a qualitative assessment. But now there is also the point of care where you can check it with, like, similar to you check your creatinine and glucose, and there are many of them that are FDA approved, and hopefully we'll implement it in our lab. And since implementing this, we've cut down on our rate of non-diagnostic studies significantly. In terms of diagnosis by histology, I mean, it's sometimes challenging, and this is one of these cases that we had that I showed you earlier. This patient had multiple biopsies, including LV guided biopsy, and all of them turned out to be fibrotic changes, non-specific. It wasn't because this patient had an end-stage kind of scenario where there's a lot of end-stage fibrosis. But it wasn't until this patient was explanted until they diagnosed the non-gaseating granulomas on the explanted heart. So sometimes the fact that you have a negative biopsy does not completely rule out cardiac sarcoid. And now there are studies that are looking at imaging-based cardiac sarcoidosis diagnosis based on MRI and PET versus biopsy diagnosis. And in fact, both of them have the same outcome. So if you diagnose it, if you have extracardiac sarcoid plus imaging criteria, these patients most likely have cardiac sarcoid, and they need to be treated accordingly. We know that similar to MRI, cardiac PET also has prognostic implications, and so if there is involvement in the left ventricle with the scar, then there is actually poor prognosis. And this is a meta-analysis that our group published looking at different studies that found that in terms of FTG uptake, whether it's in the LV or in the RV, both of them are actually prognostic in terms of having events. So how do we fit it all together? I think it is very much dependent on the patient, but the general rule is that you start with CMR for these patients. If you are suspecting cardiac sarcoid, and if you have a normal CMR, that's actually almost makes the yield of cardiac PET very low. The only time that we recommend to go to cardiac PET after CMR, even if the CMR is negative, if there is very high suspicion or clinical suspicion and you want to confirm the finding. If there is positive, there are changes on cardiac MRI, then you need to get PET to determine if this is active inflammation or this is chronic scarring, and then PET can be repeated after to assess response to therapy. There have been a lot of emphasis on PET-MR as a single machine, but the good news is that we can even fuse them and determine, like for example, this patient has a scar there which is not actively inflamed, and there is also another scar here, or LGE, with an area of FTG uptake. So you see two patterns in this patient, one prior scar which is probably not actively inflamed, another one which is actively inflamed. And we follow these patients. So patients often have one or two MRIs in the beginning to make the diagnosis, but they come serially for cardiac PET, especially to titrate their therapies, because these immunosuppressive therapies, you don't want to keep the patient on them longer than they should. Now what we see here, you see a patient who have significant LV uptake of FTG, and this patient had actually sudden cardiac arrest and a biopsy-proven cardiac sarcoid. After 3 months of steroid therapy, actually there is no more uptake, and it's all in the LV. The case is not as rosy always. Sometimes you see some residual inflammation, and we can also assess the amount and extent of inflammation. And so in treatment, we can see like how much is FTG uptake, and there is a unit called standard uptake value, which tells us the intensity of the uptake, and then we can see how much, like for example, this patient has significant improvement, but there is some residual activity there, and it's usually referred to the treating physician to decide how much to continue and or intensify or decrease the intensity of their medical therapy. And sometimes, because many other organs are in our field of view, we can see, for example, this patient had cardiac inflammation, but also had significant extracardiac. Now the cardiac is gone, and the extracardiac have decreased, but not completely gone. And obviously, the treatment is not only for the cardiac, so we give them information about the status of the extracardiac inflammation there. So one thing to keep in mind, that not every FTG uptake is cardiac sarcoid, and it can light up in any inflammatory cardiomyopathy. So what Dr. Shah spoke about in terms of SLE, we had IgG4, we had many other cases where inflammatory cardiomyopathies can light up. This is like one case report from the literature where you have very kind of faint uptake in the myocardium. This turned out to be amyloid. We're also now learning that there are some genetic mutations that are associated with some FTG uptake. Some of them are more faint than the other ones, but you can see here some of them are related to the hypertrophic cardiomyopathy or laminin cardiomyopathy, and they do light up on FTG. And we have an ongoing protocol here looking with Dr. Kasi, looking at patients who had FTG PET and trying to do genotype to understand. So not everything that lights up is sarcoid, but it can be many other conditions, including genetic cardiomyopathy. Sometimes we look at inflammation outside the heart, like for example, this patient who had thickened aorta, some calcifications, even some stenosis in their great vessels. And then when you go ahead and do FTG, you see that some of it is chronic, but some of it is really actively inflamed. And this is actually a patient with Takayasu arteritis who's been followed up by one of our cardiologists here. And incidentally, sometimes when we're looking for sarcoid, we don't see sarcoid, but this patient actually has late gadolinium enhancement in the pericardium, and you can see the significant FTG uptake in the pericardium. And I thought there was another case, but yeah. So, and sometimes we see it if there is thickened pericardium on the CT, we do see sometimes FTG uptake in the pericardium. So, although we're still using MRI primarily for pericarditis, I think this might emerge in the future as one of the potential applications. And this is your code before we move on to the other cardiomyopathy. Put it 1 second. All right, 1, 2, all phones down. All right, so let's move on to amyloidosis. And amyloidosis actually used to be a nuclear cardiology free zone where it did not have any role for many years. And there was an attempt back in the 80s to do some imaging of amyloidosis by nuclear cardiology, but it failed miserably, and we'll tell why it didn't show good sensitivity and specificity. It wasn't until people realized that when you get an MRI like this, and some of the cases that Dr. Shah showed earlier, when you get an MRI like this, this is most likely amyloidosis, but this can be either AL amyloidosis or ATTR amyloidosis, which used to be called senile amyloidosis. And what people didn't recognize in the 80s is that usually the PYP, or the bone avid scintigraphy, is going to be positive among patients who have the ATTR amyloidosis. It's going to be completely negative for this. So I'll tell you later on the algorithm, how we start with these patients in terms of diagnosis, but I'm going to focus. So if we have a patient who's suspected with cardiac amyloidosis, what do we need to do in terms of nuclear to differentiate? So nuclear cardiology is not to diagnose amyloidosis, but more to differentiate between AL and ATTR amyloidosis. So what was used is PYP scan, which is technically a bone scan. So this is it's a bone scan agent. It used to be, there were some studies done here to look at prior myocardial infarction. So if a patient comes in, so Dr. Mamarian used to do some of these studies many years ago, where patients would come in with an MI and they want to know if it's a recent MI or old MI, they will do a PYP scan. If it lights up, it will help in the diagnosis. But that didn't pan out too much until this paper that made kind of this whole field come up like almost 10 years ago, which said now we can grade myocardial PYP and try to look at it more on a planar imaging, which is like a chest x-ray, or a SPECT imaging, which is like kind of equivalent to your CT, so it's more of a tomographic imaging. And what we noted is that if there is significant uptake in the myocardium, then this is it was very specific and had very high positive predictive value to have ATTR cardiac amyloidosis if AL amyloid was ruled out. So initially there was so much focus on planar imaging. I want to leave you out with one message. Planar imaging is out. So although it's still going to be we're going to start hopefully to phase it out, because planar imaging could be deceiving for some patients and for the diagnosis. So now we're focusing primarily on SPECT imaging. This is the paper that made the whole kind of field in terms of diagnosis of cardiac amyloid. These are patients who are suspected to have cardiac amyloidosis. So these are patients who had either an echo that's suggestive, clinical history, or MRI that's suggestive. 1,200 patients. When you have a grade 2 or 3 uptake, so either uptake equal to the bone or more than the bone, then there was 100% specificity and 100% positive predictive value for ATTR amyloid. Now the numbers look too high. That's probably very much because the prevalence of disease in this cohort was almost 70%. So it is very high, and that's why you have the very high positive predictive value. In the meta-analysis, it's ranging around sensitivity of 92 and specificity of 95%. So we moved on, the whole field has moved on completely to SPECT imaging. So the diagnosis we make is based on SPECT imaging. So if it looks like an MPI for you, like a regular nuclear stress, then this is grade 3, and this is like the very highly suspicion. So SPECT imaging, it helps primarily in the blood pool to differentiate it from myocardial activity and the location of the uptake. And this is now in our center for the past 4 years, we've been doing only SPECT CT, and this is kind of where it adds even, because I think it becomes very difficult if you don't have anatomical landmarks. So with SPECT CT now we see where the uptake is. So I see it in the septum, I see it in the lateral wall, I know where I to co-register, and this is going to be very helpful for co-registration and enhances our sensitivity. Why did we phase out the planar imaging? Because if you have a ratio of 1.5, that could mean there is no uptake. It's all in the blood pool. So although you see it this much here, when you look at it, you see that there is no uptake and there is all in the blood pool. And this had been initially one of the sources of frustration when people were doing just planar imaging. On the other hand, you can see also something very similar. So if you have also a very high ratio, you can still not see anything in the blood pool. So personally, I think PYP imaging should only be done on SPECT CT. The guidelines now make SPECT kind of like highly recommended, but hopefully that will be changing in the future. You need to be aware of many false positives and false negatives. So one of the false positives is AL amyloidosis. So about 4% of AL amyloidosis will have positive PYP. And that's why to be able to say that this is ATTR amyloid after a PYP, you need to measure the kappa and lambda and make sure that they are normal. Other than that, you could still be missing about some AL amyloidosis. We had our share, few cases of hydroxychloroquine toxicity. We had a couple cases that turned out to be hydroxychloroquine. If there is rib fracture, pleural effusion, sometimes they could affect it. Blood pool is the biggest source of false positives, and recent MI, because PYP does light up in patients with recent MI. There are some mutations for ATTR amyloid that are known not to take up amyloid. They are not the most common in the US, but there are some of these mutations that actually have negative PYP. And there are some early disease states where you're not going to be able to see that intense uptake. If you waited too long and the tracer have decayed, or you injected little dose, or you imaged the patient for little time, or if there is large pericardial effusion, that will decrease the counts and you image them. And sometimes breast implants may hinder the imaging. However, if you're using SPECT CT, many of these could be all taken care of, and then that will be accounted for when you're looking at these images. Now, every now and then, if you look in the report, we do have sometimes, in the past year or so, PYP has been a hit and miss, sometimes available, sometimes not. So there are few other bone scan agents that we can use. It's another one that we are using is HMDP. So compared to PYP, we noted that HMDP, initially it was thought that you should image it at 3 hours, but now we're learning that you should image it earlier, and we moved to 2 hours, and maybe we'll move even earlier. But you get something very similar in terms of uptake, and potentially has similar diagnostic accuracy. At least the yield of studies that has been reported has been similar by different labs in there. So this is the most important slide. So when you are on heart failure or you're on the wards, you want to make a diagnosis of amyloidosis. This is not a screening test. So the first thing, the patient selection, is that somebody who had heart failure had echo or MRI that's suggestive of amyloidosis, and you've done your kappa lambda and they are coming negative, and you have PYP scan that's positive or HMDP, now you can call it ATTR amyloid. With this criteria, then so it's not for somebody who's completely asymptomatic, then your false positive rate is going to go up. It's not for someone that you have not checked kappa lambda, because you still could be having about 4% of them AL amyloidosis, and that's something very important to keep in mind. After you make that diagnosis, then you just go ahead and do genetic sequencing to see if there is any genetic mutation, because there are two types. There is the senile and then the wild type, and then there is the genetic type, and then it has implications for the family if it's genetic to be actually tested 10 years before the diagnosis of the index case. So to sum it up, again, positive PYP does not mean ATTR. Positive PYP plus negative kappa lambda in asymptomatic patient, that means ATTR. Always screen for AL. And finally, again, my pitch is that we're going to do SPECT, and specifically SPECT CT. Always perform SPECT CT for these patients. So when you move on to practice and you want to do it and you don't have SPECT CT, don't try to do it, because you may be mislabeling some cases, and the sequential implications for these patients are major. Some patients have been put on tafamidis unnecessarily because it was not very clear from the imaging whether it's a blood pool or myocardial uptake. So I think with this I'm going to stop, and happy to take any questions. If none, all clear? All right, you can read PYPs tonight. Thank you.